Hello, everyone, and welcome to the sixth webinar in our 2022 ASPA FLEX webinar series. And to all the fathers who are actually joining us today, happy Father's Day too. Let me introduce myself. I'm Evangeline Lim. I'm one of the consultants at the Department of Pediatric Anesthesia at KK Women's and Children's Hospital, Singapore, and I'll be one of the moderators for today's webinar. Joining me today is my co-moderator, Dr. Pichaya Watayawinu, who is an assistant professor practicing anesthesiology at Suriraj Hospital, Mahidol University, Bangkok, Thailand. And together, we are actually very privileged to be able to present to you a webinar entitled Beyond Stridor in the Pediatric Airway. Providing anesthetic care for our patients undergoing airway work is always challenging, whether in adults or children, but it's definitely more challenging in pediatric patients due to their anatomy, physiology, and size that makes them less tolerant of repeated airway manipulation and also predisposes them to rapid desaturation and hypoxia. It is therefore important to understand our limits and work closely with our ENT surgeons and pediatricians to ensure that our children get the best possible care when they undergo airway procedures. Today, we are privileged to have with us 3 speakers to take us through the different aspects of pediatric airway management. Firstly, we have an ENT surgeon, Professor Henry Tan, give his talk on pediatric airway, difficult conditions and alternative treatment methods, where he'll take us through microlaryngeal bronchoscopies or MLBs and many more surgical procedures to give us an insight to the surgical knowledge that anesthetists should have in order to be able to provide the conditions for our ENT surgeons so that they can operate and work safely. He will also highlight how close collaboration between anesthesiologists and surgeons can actually lead to innovations in airway management. Secondly, we have Dr. Nandini Devi, who actually speak on anesthetic considerations for pediatric airway surgery. And lastly, we'll have Dr. Josephine Tan take us through a case involving a respiratory compromised patient undergoing a challenging bronchoscopy. And she'll also touch on the ventilatory strategies that can be employed to ensure that such a child remains oxygenated and well during bronchoscopy and afterwards. We are also very privileged to have with us a special guest panelist to join our Q&A session at the end, and he's none other than Professor Joseph Holsky, who is renowned for his work on the pediatric airway, in particular with regards to cuff endotracheal tubes. So before I hand the time over to our speakers, we have some housekeeping rules. Firstly, I just want to highlight that questions and comments can be entered via the Q&A section of this Zoom meeting. Please note that chat and raise hand functions have been disabled, and your questions may actually be answered by the respective speakers during in the course of the via text, or alternatively, our moderators will highlight some of the questions to the appropriate speaker during the panel discussion. I seek your understanding ahead of time if we are not able to cover all questions during this time, but we'll try our best to answer as many questions as we can. Secondly, for those of you who actually require a certificate of attendance, please note that this will be automatically generated and forwarded only if you have actually submitted a post-webinar survey, which will be forwarded to your email tomorrow at 1700 hours Singapore time. Please ensure that you have correctly keyed in your full name as well as email to ensure that you have your personalized certificate of attendance sent to your email address. I would also like to highlight, of course, that you can follow us on social media, on YouTube, Facebook, as well as invite you to visit our website at the Asian Society of Pediatric Anesthesiologists. Okay. We would also want to have some polling questions, okay, in the course of our webinar series. And please note that when a poll is launched, you'll be prompted to answer the polling questions, and you have 30 seconds to answer and submit your answer. And after the results of the poll have been posted out, please remember to actually close so that continue to actually see the rest of the webinar and follow through the rest of the webinar. Okay, so without further ado, let me introduce, our first speaker. He's none other than Professor Henry Tan, who is actually a senior consultant at the Department of Otolaryngology at KK Women's and Children's Hospital in Singapore. He's also a clinical associate professor at the National University of Singapore, as well as at Duke NUS. And whilst he actually received his medical degree from the University of New South Wales in Australia, he actually underwent training in the UK and then followed by specifically in pediatric ENT training in Chicago and Boston in the USA. He is well respected, for his clinical expertise in managing the pediatric airway, and can actually see that his interests lie in pediatric airway disorders and otologic implants. And he has more than 60 peer-reviewed journal articles. So without further ado, before we actually get started on Prof's talk, we just want to run one poll question, as a prelude to his talk. The question that we want to ask is, have you actually participated in an exit procedure? Yes or no? You have 30 seconds, to actually enter your answer. Okay, those of you who haven't answered the poll, this probably will be the last few seconds, before we actually will close it off. And we can actually see the majority of you actually haven't participated in an exit procedure, about 70%. Okay, so without further ado, let us listen, to Prof talk about the pediatric airway difficult conditions and alternative treatment methods. Take it away, Prof.
Good afternoon, ladies and gentlemen. I'll be talking on pediatric airway, difficult conditions, and alternative treatments. My agenda today will be in the following. Tracheal obstructive lesions, I will talk on two cases of exit case, and after that, I will follow by laser surgeries in pediatric airway, replacement of laser by cochlear microdebrider, cold knife, and medication. And then finally, I will go on to innovation and special treatment with application and the use of rigid endoscope and flexiscope to secure the airway for difficult intubation cases. So first, cases of tracheal obstructions. Number one, I will present a case of tracheal esophageal fistula, followed by congenital tracheal stenosis. So case one is the ex-prem 27 plus 1 week delivered via emergency LSDS. Day one of life, he was diagnosed with a type C TOF, which you can see is here. And MLB shows a mild tracheal malacia about 10%. There's a tracheal esophageal fistula located just above the carina. Day two of life, he underwent ligation of TOF with gastrostomy creation. And at 3 months of age, this was complicated by reopening of the fistula. He underwent right thoracotomy with repair of TOF, revision, and underwent the second MLB with the insertion of forgetting catheter. Following that, he had frequent internal code blues and airway codes due to mechanical obstruction, secondary to secretions as well as ETT malpositioning. He had a third MLB for reassessment in view of multiple failed extubation attempts due to posterior tracheal wall collapse from the mid-trachea down to the carina. And he started to improve. And there's a fourth MLB done with the travel extubation. However, after extubation, he had increased oxygen requirements with significant apnea and cyanosis. Thus, he was re-intubated. And the fifth MLB shows that there's still mid-tracheal narrowing as before, and the tracheostomy was offered at 7 months of age. with the insertion of a size 4 Bavona adjustable tracheostomy tube, which I will introduce more to you what it is. And the tip of the tracheostomy tube was adjusted to beyond the area of the Malaysic segment, but not touching the carina. And there's only a 5 mm gap between the carina and the inferior edge of the Malaysic trachea. So this is the video of the trachea about 1 week after tracheostomy. You can see there's some suprastoma granulation. After I go further in, the Bavona tube is in place. Upon withdrawing, I just want to show you how much tracheal compression it is with the tracheal Malaysia from posterior to anterior wall. So as we go down to the carina, you can see the old tracheoesophageal fistula opening, left, right main bronchus. And as I come back, you can see the wall is opposing anterior wall with that collapse. It's an almost complete obstruction. So over here, I will try to introduce the tracheostomy tube to you, especially the Bavona adjustable. So tracheostomy tube is a Portex, Shiley, Bavona, as well as metal tubes. And this is a Shiley, this is Portex, this is non-carved, this is carved. And this is metal, and this is Bavona ordinary tube. So you can see they are quite short. And this is Bavona, they are actually very long. The function of that is not only for ventilation, but also for stenting. The length can be adjusted by moving this flange here up and down. So normal tracheostomy only stops short here. So the rest of the airway are not touched. Whereas the Bavona goes right down almost to the carina to stent and open up the airway where the collapse is. So after the Bavona tracheostomy tube insertion, he had still multiple episodes of high ventilation settings and CO2 retention. Multiple tracheoscopy through the tracheostomy tube with the endoscope. Then done to with the Bavona tube adjustments done to relieve the obstructive episodes. He had 6, 7, 8 MLBs done following that, and then he actually had some tracheal Malaysia down to the carina, but the narrowing segment now is 2 centimeters proximal to the carina. So it's more airway now as the child grows. He had the 9th and the 10th done. And then after that, he had a 50% patency. As the child grows, the tracheal Malaysia improves, scarring become stronger, and the airway opens, as can be shown in this video here. So as you can see, the suprastoma granulation still a little bit there. The tube is removed. There's some tracheal Malaysia, but the airway is more or less opened to about 70–80%, all right? The old scar still there. The second case is a male infant born with at 36 weeks via the elective LSTS. He was transferred from a private hospital on day 2 of life for imperforated anus and BSD. He underwent double barrel colostomy without any sign of airway obstruction. So he was intubated under anesthesia with size 3.5 ETT, and the larynx was grade 1. However, the anesthetist encountered resistance in advancing the endotracheal tube. It was anchored at 8 centimeters and the surgery proceeded. Post-operatively, they managed to push the tube further in and secure at the lip at 9.5 centimeters. However, he developed respiratory problems on day 4 of life with ventilatory failure and multiple desaturations down to SpO2 over 10%. So urgent CT was done. which shows a long segment of tracheal stenosis with the narrowest part being 1.1 mm diameter. He also had a left pulmonary artery sling. So urgent MRB was done, which shows the stenosis at 2.2 centimeter from the vocal cord. Granulation at the left posterior part of the stenosis was noted and was unable to pass a 1.9 rigid telescope, which I'll show you in the video. So the tube is removed. As you can see, the vocal cord is here, the subglottis, the trachea, and then at about the mid-trachea, you can see the granulation, still bruised, a bit of ecchymosis there. And then the white area will show you is previous trauma. That means the tube has sit there before. I was trying to use a 1.9 mm scope to go through and have a look at the carina, but we are unable to go through. So 1 week down the road, we do a repeat scope after steroid treatment. These are tons of granulations. And then we're able to look down. So there's some reduction in edema, the superior part of the obstruction and the trauma still there, which you can see. And then I'm trying to use a 1.9 scope to go through. So 1 week after this, with steroid treatment, I was able to go down to the carina and have a look at the complete ring area and the stenotic area. That's the carina, all right? So the child now is actually, at the moment, cannulated, CPAP overnight, and then we will wait 2 months before we do the tracheoplasty. But with this case, the lessons we learned is, which I'll put forward, that the anesthetist should actually suspect and can assess whether there is tracheal stenosis using a flexiscope, which they are well versed with. But if they want us to use a rigid, we will be happy to be activated at any time. So that we can give the warnings that should and can be given early to a patient with tracheal stenosis so that we can place the ETT short of the stenotic area and also avoid suction trauma by the nurses in the ward. All right, next, cases of cervical teratoma with exit procedure. Patient-needed exit are usually life-threatening and difficult. What is exit? Exit stands for ex utero intrapartum treatment. And it is a specialized life-saving procedure to deliver babies while maintaining maternal fetal circulation. Without that, the infant may die. So this case is born to a 35-year-old G3 B1 mother, presented to KK at 26 weeks with threatened abortion and chest infection. Ultrasound at 19-week gestation was normal. At 26 weeks, is noted a homogeneous mass 4.8 by 4 by 3.7 below the mandible. She also had polyhydramnios. MRI was done, which shows the same mass in the fetal neck with significant airway obstruction. The mass increased in size with the ultrasound at 28 week and 29 week. Now it is about 7.6 by 6.9 by 6.6. So the decision for exit procedure was called for with the interdisciplinary conference held with the maternal fetal team, pediatric ENT, pediatric anesthesia and neonatologist. Exit team was assembled and pre-procedure preparations and practice were made. So a simulation practice was initiated by the anesthetist, all right, Dr. Joe Tan. So the mother, how the baby is going to be delivered and how are we going to take care of the baby when they are out. An algorithm of the airway management was made from direct laryngoscopy, try to see whether we can get the airway, to flexible endoscopy, to tracheostomy. If that failed, resection of the mass. If that failed, to ECMO. So the real exit procedure occurred at 31-week gestation. The mother had regular preterm contraction, rupture of the membranes, and fetal distress. The exit team was activated and cesarean section initiated within the hour. So normally you get a lot of people in these type of cases. They are exciting. So direct intubation was tried, was not possible. Flexible nest endoscopy was tried and unable to intubate the airway. So decision was done for tracheostomy. So the child is half-born, still attached to the placenta. Tracheostomy was done on the mother's lap. The right arm is delivered. Tracheostomy achieved. The next case related to exit is a cricoid atresia case, which was born to a 36-year-old G1P2 mother. It's an IVF twin pregnancy. Ultrasound scan was actually normal. So elective C-section was done. Twin 1 was normal, but twin 2 born hypotonic cyanotic, and code blue was activated. The neonatal team had a positive masking. Multiple intubation attempts was unsuccessful. So airway code was activated. Then the anesthetic team and ENT team arrived with repeated attempts by the anesthetists with different size ETT, cuffs, stylets, etc. But it was unsuccessful. Chest compression started, and then eventually I had a look. Direct visualization, review structural obstruction at the blind end, which suggests laryngeal atresia. So emergency trach was called for only at 51 minutes of life, unfortunately. So at 55 minutes, we were able to get a SpO2 84 and heart rate 87. After 8 minutes, we achieved the tracheostomy with the insertion of a 3 mm tracheostomy tube. It was, the situation deteriorated again because of pneumothorax, which improved with needle decompression. At 72 minutes, we get a better vital, and 84 minutes, it was more or less a normal vital when we sent to ICU. However, there was actually too long in resuscitation, and severe hypoxic ischemic damage was done to multiple organs with encephalopathy, cardiorespiratory failure, acute renal failure, and coagulopathy. Continued deterioration occurred. Baby passed away at 18 hours of life, and full post-mortem consent was obtained. And this is the post-mortem specimen with the tracheostomy stoma, and the cricoid, as you can see, is totally cartilaginous and is not open at all. So it's a treat cricoid cartilage. So the lesson learned from this case is, to save time, I think maximum travel intubation from each department or specialty should be, decided by, for different hospitals, the different ideas, either 2 or 3 times in each time, so that we don't use too much of a time to save the child and eventually the brain damage. So next, I will proceed to laser surgery in pediatric airway surgery. We offered to patients with laryngomalacia. So this is how it's done: supraglottoplasty, to valvular cyst, to saccular cyst, post-laser, to subglottic hemangioma cases, as well as laryngeal papilloma, intubation, tons of granulations, obstructive granulomas, adhesions, and subglottic cyst, single or multiple. And at this juncture, I'd like you to pay your attention to this, Lindholm laryngoscope, which I will introduce to you later, because most of the cases will be done under this scope. Cases with subglottic stenosis will be offered as well, and trachea web. Now, laser surgeries, there are pros and cons. It is bloodless, it is precise. However, you have to worry about laser fire. It is dangerous to others in the theater. Injury to the deeper tissues is a concern, and they are expensive. Preparation takes a longer time as well. So I will, go on to the next few slides to show you the length, the danger, and how much we can change to laser surgery. It is now done less common. So in this case, I'm going to show you, this is the Lindholm scope, and then this is a case of valvular cyst. I just want to show you how long we take for the preparation for the laser to be done, all right? This patient is done under endotracheal tube, is intubated. The tube is below, so the cyst is exposed with the Lindholm laryngoscope, which I'll go in more detail later. So lasers are done. The video is actually double speed. And then I want you to sense how long it takes as well, all right? And then how short it takes with a new treatment. So after you laser, and then a lot of times you combine with scissors to remove or uncap the cyst. So the cyst is burst, suck it out. Although it is bloodless, sometimes with the combination of scissors, there might be a bit of blood, but it can be controlled usually. So I will let the time roll to finish this video because I need you to sense how long it takes. Although it's not very long, but it takes longer than other methods. All right, it's almost done. Okay, so it is done. So the next one, this case is done under laser with from laser to coblation. So coblation is a much faster procedure, which I'll show you now. That after intubation, how we achieve that, I will show you later. So I have a special way of achieving the intubation in this case, which is part of the talk, which I'll show you later. So after the intubation, now we come into the cobblator. What is coblation? I will also explain to you later. So we coagulate this, and then after that we burst the cyst, and then we suck the content out, and it's like really very fast. And then we remove the wall of the cyst using coblation as well. And in this case, you don't need to worry about fire like the laser. Those burn injuries are usually very little. Is like a hot coffee burn, 70 degrees centigrade compared to diathermy. And we don't worry about burning the tube at all. And the pain is minimal. All right, so we are done with that. So coblation has replaced laser in this type of surgeries. Now this is the Lindholm laryngoscope, which I'm trying to introduce to you. This is the baby one. This is an adolescent and an adult. The side tube here, you can insert to insufflate oxygen in a case where you use total intravenous anesthesia. And the cobblator is a surgery that uses radio frequency energy. The radio frequency energy come to the metal here. It's a bipolar type of surgery, so it's localized. And it's a low heat of 70 degrees centigrade, like a hot coffee. And coblation is actually also called plasma surgery. They are the fourth state of matter. So from solid liquid gas, now is plasma. What is plasma? It is actually in the presence of normal saline, the normal saline is break down into sodium and chloride ions, and it's ionic surgery. After you break down the tissue, it is sucked out, all right, and that's called coblation. Now, treatment of papillomatosis, previously, a lot of time we use laser, but now we also change to microdebrider, which is precise and less traumatic. So it is a metal tube, which is we call a skimmer. And then there's a knife inside a metal tube, which I will show you in a second, that The suction sucks the tissue in and then it just churn out. If there's any blood, the blood will be sucked out so that you can see the tissue precisely and where to take out. And how deep you want, you can gently adjust. All right. So I will give it a bit longer to show you the actual blade. So the churning action and the suction is very gentle. So it's called a skimmer, S-K-I-M-M-E-R. So you just remove the tumor with this metal tube. Inside there's a suction and it is a churning knife. All right. It is very fine. Okay. I will show the video a little bit longer for one of the lesions to be removed, just to show you how gentle it is. So this one, there's some papilloma here. We will slowly trim it out without injuring even the mucosa. There's a blood there, never mind, we can suck it out and then we can trim the tumor out precisely. So in papilloma surgery, you don't aim to like dig in and injure the organs, all right? Important is for you to remove the lesion every time to preserve the organ and preserve the function. Is actually, we know, is a non-curative, but is a palliative therapy, all right? Okay, so I'll stop there. Next group of lesions for laryngomalacia. We know it is causing 60% of the stridor or obstruction in pediatric airway, but only 10 to 20% will have such severe symptoms that they need surgery. And these include patients with apparent life-threatening events, called pulmonary, failure to thrive, and feeding difficulties. And the options of surgical treatment is CO2 laser, which is now more or less replaced by cold knife, microdebrider, or cobblator. So I will show a little bit of laser surgery for you on cobblator. This one is tubeless. Patient is under total intravenous anesthesia. So we do a MLB first to make sure there's no other lesions. Then we suspend with the lean horn, which I show you the scope, with a big mouth so that we can expose the larynx properly, aim the laser light, and you don't need any decongestants, all right? And you know you want to divide this and then take out the soft tissue here. And that is supraglottoplasty. So the laser is done, more, and then we do more on this. As long as the posterior glottis is not involved, so that there will be no aspiration symptoms. All right. And after that, we do the other side. So that's laser supraglottoplasty. And nowadays, because of the setup, because of the pain involved, that we need antibiotic, post-op, etc. Now we actually change to cold Caesar. They will do the same job. You decongest. There won't be much bleeding. The patient can be tubed so that you have all the time you need, and anesthesia becomes easier. And then you take the supraglottic soft tissue out. Pain usually much less compared to laser surgery. All right. Done, and then we do the other side. Okay. Now, for cases of subglottic hemangioma, 30 to 70% mortality if left untreated. And the treatment also, we use repeated lasers, maybe 1 time, maybe 3 times, maybe 10 times. You can do other surgical procedures to treat this condition. But nowadays, medication is doing the trick. The discovery of propranolol for treatment of hemangioma has cut down lasers and surgical procedures. So I will show you in this case. This patient has got a right subglottic hemangioma, which obstructs 80% of the airway. All right. This is the MLB. We look down the airway. This is the air bubble. Because he was symptomatic, he was desaturating, so we have to reduce the hemangioma a little bit first before we start propranolol. And after that, you don't need to repeat the surgery anymore or laser surgery anymore. So laser partially remove the hemangioma. To an airway of about 60% so that the propranolol can be started. So you don't want to go too deep as to injure the cartilage. Then propranolol is started, and in 3 months down the road, I want you to see the difference just with propranolol treatment. As you can see here, 3 months of propranolol treatment will shrink without further surgery the hemangioma to this level. All right, there's still some inkling of something there, but 8 months down the road, with the treatment of propranolol, you can see the subglottis is now completely like normal airway. So propranolol works by vasoconstriction. They regulate the growth of the hemangioma by reducing the basic fibroblast growth factor, reducing the vascular endothelial growth factor. And they also promote apoptosis. So it's an amazing medication that replaces laser treatment. Last and not least, I will do some innovation talk. Innovation is by one of our anesthetists. This is a case of a child born with pharyngeal atresia. He was unable to oral feed from birth. So you feed milk, the milk will come back out from the mouth, all right? Because the pharynx is not opened. Parents refused G-tube, all right? Initially, flexible intubation via the nose and the trach was done. Atretic plate was laser creating a pharyngotomy. But then if you don't stent it, this will heal back in no time. So stenting was done with a modified stent for about 1 year, which was actually invented and created by the anesthetist. So the ETT was used, and then this one using a hot wire, making 2 holes, and then the ET was cut to fashion the shape, and then to freeze the flower shape into position. And that is how it looked like at the end. And then we stent the pharyngotomy and change monthly for a year. Eventually, we were able to use a better material by cooperating with the university. And then after 1 year, his pharynx is actually open. You can see the epiglottis over here. And we have solved his problem. Initially, we can feed through the orogastric tube when he was young and avoid a G-tube. Saliva was able to flow down to the esophagus and swallow rather than drew out through the mouth and wet the cloths, the shirts and everything. He developed oral feeding later, and eventually he developed speech and language, and his tracheostomy tube was decannulated. The novel stand of the treatment and persistent vagal-pharyngeal membrane, the paper was published. Related to the innovation, for cases with difficult intubation and use of endoscope and flexiscope, in ENT, we have a range of rigid scopes, right? Either 0, 30, 70, 120, and the size from very thin to 4 mm. So what we do for difficult intubation, we cut the ETT and then we sheath over either a 0, a 1.9 telescope or 2.7, depends on the age of the neonate or infant with difficult intubation. Difficult patients usually, as you can tell from Pierre-Robin syndromes with micronatia and glossoptosis, Naegel syndrome as well. So with a patient like that, I'm going to illustrate how we use the rigid telescope for intubation, all right? In this case, this is the laryngeal cyst I showed you before. The cyst is completely obstructing the larynx. So you cannot see the larynx at all. The cyst is in front. So we are using the rigid 30 degrees, 2.7 with the ETT sheath over. Because it is slim, so with the help of any laryngoscope, the telescope is introduced with the ETT sheath, and then you go in, you push the cyst sideways. You know exactly where the larynx is because you can see with the lens at the tip of the scope. And then after that, you aim for the inlet, push the cyst to one side, and then you enter the airway. After that, usually we go a little bit deeper before we slide the ETT down the airway and secure it. All right. So once you're in the airway, you confirm in the trachea, and then the ETT is inserted, and then the surgery is done. All right. This is a patient I showed you before. We use a flexoscope to secure the airway, but because of the severe glossoptosis, the patient's ETT will come out easily, and then you have to, try to intubate again. But honestly, the ETT is really hard to secure in place. So you sometimes have to gas the patient just using a facial mask. And if that is not too difficult, this one will be more challenging, all right? This is a 1.5-year-old boy with the bony mass from Philippines. When he was 1.5, he was like this, and then the surgery was delayed because he's anemic. 3 months later, his mass become so big that the nose are obstructed, the mouth are obstructed. So in this case, I suppose you just have to innovate and see what mask you can use to gas out this child as he still can breathe before a trip is being done. So with the experienced anesthetic team in KK, and with our friendship, trust, and good communication, and then with the help of difficult special instrumentations, a lot of difficult airway surgeries and cases can be done. Thank you for your attention.
Thank you very much, Professor Henry Tan, for your very informative talk. The cases that you share with us today are so impressive. And because during microlaryngeal bronchoscopy or MLB for these procedures, the ENT surgeons and anesthesiologists share working space. So we must understand the surgical process very well, which Prof. Henry gave us everything. So, and other than that, Prof. Henry also showed us the initiation technique using rigid bronchoscopy for intubation, which is interesting because there's another choice of intubation other than the flexible one that we use. And he also showed his novel surgical equipments that becoming more useful nowadays, including coblator and microdebrider. So we know about these equipments right now. Moreover, there's some other important key messages that I think that it would be really useful for us. For example, like if we are dealing with complex cases, it needs really well planning so that the outcome is better. When you see at the exit case that everything went very well, and with simulation is really, really helpful as well. Other than that, in case that you feel that there's some things not quite right, you should stop and think about the possibility of the causes. For example, if we cannot push the endotracheal tube downwards at the level that we want, so there must be some obstructions, stenosis below that level, which should be looked for. And we cannot, just easily put the flexible and endoscopic in to see what happened. But if you see that problem, you cannot pass the tube in the newborn, that's a really rare case. which is quite interesting. The laryngeal atresia, it does happen. It does happen to me once. And if we really understand that this condition is really exit, maybe intubation is not the good answer for that. So now I think that most of you, during looking at Prof. Henry's cases, you're thinking about how you give anesthesia to those kids. So this will be covered by Dr. Nandini's talk. So I would like to introduce our next speaker, Dr. Nandini Dave. She'll be giving us the talk in the anesthesia considerations for pediatric airway surgery. So Dr. Nandini is a senior consultant and head of department of the anesthesiology at Children's Hospital, Mumbai. And she also a vice president of Indian Association of Pediatric Anesthesiologists. Her field of interest include medical simulation, pediatric regional anesthesia, and safety and quality improvement in anesthesia. So this is the talk that most of you are looking for right now. So please welcome Dr. Nandini. So she's going to start with the poll question.
Good afternoon, and thank you to the organizers at ASPA for this privilege to speak. I bring greetings from SRCC Children's Hospital. We are a tertiary care multi-speciality children's facility located in Mumbai. I have no conflict of interest. And at the outset, I would like to thank our ENT colleagues, Dr. Easy and Dr. Anju Chaudhary, with whom we have a great rapport, and it's great fun doing challenging cases together. So I've been asked to speak about anesthesia for airway conditions in children. And we have a real spectrum of airway conditions with which children can present to the operative room. And these can be either congenital or acquired. And the children can present for either diagnostic procedures under anesthesia. And following the diagnosis, they can be coming back to the operating room for treatment of those conditions. So what I've planned for this session today is talk about the anesthetic principles of shared airway surgery, discuss the spectrum of anesthetic techniques, and talk a bit in detail about airway procedures such as foreign body removal, drug-induced sleep endoscopy, and laser walk. Before I begin, some questions for the audience. For DISE, that is drug-induced sleep endoscopy in children, the preferred anesthetic is A, propofol, B, ketamine dexmedetomidine combination, or C, sevoflurane. The second question is regarding inhaled foreign bodies in children. Most foreign bodies are radio-opaque, true or false? It is always a surgical emergency, true or false? And I hope by the end of this talk, the answers to these questions would be pretty clear.
Okay, so we have the answers to those poll questions. So I can see that most people, for the first question for DISE in children, the preferred anesthetic, most people say it is ketamine dexmedetomidine, and a close second is propofol. So yes, the correct answer is ketamine dexmedetomidine in children. In adults, propofol seems to be very popular, but what happens in children when you do a DISE study is that propofol tends to collapse the upper airway a lot. So it can lead to a higher percentage of, kind of false results. So ketamine dexmedetomidine is the correct answer. It is most popularly used. The second question, inhaled foreign bodies are mostly radio-opaque. It is false. A large majority of foreign bodies are actually radiolucent. So almost 90% of foreign bodies are radiolucent. Here is the third question. Third question was that the bronchoscopy procedures have to be done as an emergency. It's not always true. If it's a laryngotracheal foreign body, then it has to be done emergency. But if it is in the bronchus, you do have some time to plan to get the expert bronchoscopist to get your theater ready, and you can also do it as an elective procedure before rushing in without being prepared. Yes. Thank you.
Good afternoon. And thank you. When it comes to anesthesia for airway procedures, it is really a balance between oxygenation and airway and anesthesia and the need for surgical access. So whatever be your plan for anesthesia, one should always have a rescue plan in place. It could be a rigid ventilating bronchoscope if the surgeon is not already using one, or it could be a tracheostomy. And this is something which has to be discussed with your ENT colleagues, and it also has to be explained to the patient and the parents. Coming to the preoperative evaluation, one must look for history and signs and symptoms of obstructive sleep apnea and signs of significant airway obstruction, which could be respiratory distress, stridor, inability of the child to lie supine. Is there an oxygen requirement already? This would be a red flag because airway assessment or procedures involving the airway are fraught with difficulties, and there are several episodes where hypoxemia could occur. So if your patient is already having an oxygen requirement, that should raise a red flag immediately. About pre-procedure investigations, one really has to individualize. You may have a fairly stable child and you would want to do only maybe a complete blood count in the patient. On the other hand, you could have a child with, say, congenital heart disease, and then you would want to evaluate the child completely, send the patient to the cardiologist, do an echo, and so on. You have to discuss the airway plan with your surgical colleagues, a plan A, plan B, and also the rescue plan before you go into the OR. Airway equipment preparation, of course, depending upon the plans you have in place. We have to take each organ system into consideration and then discuss and let me talk about what are the anesthesia implications which could occur. For example, in the cardiovascular system, your child could have a structural disease, say, for example, an ASD or a VSD. And what happens is in airway procedures, whenever there is a chance for hypoxia, hypercarbia, there could be a reversal of shunt. The shunt, which was left to right in the first place, could become a right to left shunt. There is always a possibility also of paradoxical embolism. Has your child had cardiac surgery earlier? Are there any dysrhythmias? Some of these children would give a history that there is a life-threatening event which has occurred in the past needing CPR, and that's something which you must ask for. Is the child on any medications? In the pulmonary system, chronic hypoxia and hypercarbia can result in pulmonary hypertension. There may be chronic aspiration. Is there a recent URI? And all these can cause or put the child at an increased risk of respiratory adverse events during the procedure. Does the child have a syndrome? Is it a difficult airway? If there is a chance of a difficult airway, you must remember not to burn your bridges, and it's always better to maintain spontaneous ventilation during the procedure. Does your child have hypotonia? Is there a neuromuscular issue? These are children who could give you problems in the post-operative period. You must have a backup for post-operative ventilation ready. Does your child have a myopathy? He could be at a risk of malignant hypothermia. What about the birth history? If your child is premature, all the sequelae of prematurity, such as bronchopulmonary dysplasia, would come into the picture. There might be a history of a long ICU stay, and there would be, you could expect difficult IV access in such a situation. In the preoperative preparation, immediately prior to the procedure, an anticholinergic to dry the secretions, lignocaine nebulization is useful to reduce airway hyperreactivity, and I use it often. Now, sedation has to be individualized. If your patient is going to be crying, then there is an increased airway resistance, and it's better to sedate these patients in the preoperative area before separating from the parents under monitoring, of course. IV access always. Sometimes you might want to take the patient under with sevoflurane and then secure an IV access, but then access is always mandatory. Standard fasting instructions, but sometimes you might have an emergency full stomach scenario, in which case you would want to do an NG tube after induction, prokinetics preoperatively, a slight head up tilt during induction. Rapid sequence induction really has no role in pediatrics. How will you manage the airway and oxygenation? There are really 6 methods, and I'll discuss these in a bit of detail. The first is a spontaneous breathing or the tubeless technique. This is actually the best technique for surgical access, and the surgeon can work unhindered. This also is the technique to go when you have to do an airway assessment, because the surgeon can look at the dynamic characteristics of the larynx and the airway, which would be abolished if you're giving a muscle relaxant or putting a tube inside. This is a child, an infant, who had stridor, and this is an airway assessment which is being done under spontaneous breathing without a tube in place. And this child, you can see, has got type 3 laryngomalacia. The epiglottis is flopping over. This child needed an epiglotopexy. How do you manage anesthesia with the tubeless technique? You can have a VIMA technique, which is a volatile induction and maintenance of anesthesia, when you induce a child with sevoflurane and maintain also with sevoflurane using purely inhalational anesthesia. The advantage of this technique is that the patient manages his or her depth of anesthesia. So if the patient is light, he breathes deeper and faster, and he takes in more sevoflurane. On the other hand, if he's deep, too deep, then he will breathe shallow, and then he will guide his own anesthesia that way. The problem is that of OR pollution. The other technique is of TIVA, where there is no OR pollution, and a titratable degree of hypnosis can be achieved if you have BIS or entropy. The problem is if we cannot use BIS, or if you don't have access to BIS, then it can be a bit of a challenge titrating the IV anesthetic, and your patient could either be too light or he could stop breathing if he's too deep. The essential problem with the spontaneous breathing technique is ensuring an adequate depth of anesthesia while maintaining sufficient minute ventilation. The second technique is positive pressure ventilation, which is actually the best technique for us anesthetists. The advantage is that you can completely control airway and ventilation. So you can use your standard endotracheal tube. You might want to use a microlaryngeal tube, which is essentially a longer tube. Or if you're doing laser surgery, you can use laser specific tubes. The tubes can be inserted either oral or through the nasal route, or through a tracheostomy tube can be connected if the patient has a tracheostomy. Let's look at this case. This was a 12-year-old child who had come with a neck injury with a cricket bat. And this child presented with stridor and neck bruises, suggestive of an internal airway injury as well. So here what we did was, initially our ENT colleagues did an emergency airway assessment using a flexible fiber scope. And during that time, we maintained the patient on spontaneous ventilation. Following that, we intubated the child orally, and the neck exploration was done with positive pressure ventilation. So here you can see you might want to use a combination of techniques depending on what the surgical requirement is. If you look at this picture, initially you're seeing that this is the thyroid. Here the surgery is underway. So here the flexometallic tube has been inserted into the distal airway through a tracheostomy, and we are giving positive pressure ventilation. Once the surgery is over, here the laryngeal mold has been put in, and the anterior airway is being closed over this mold, and this tube will be changed into a formal tracheostomy tube at the end of surgery. The third technique is of jet ventilation. You can use either a low frequency jet, which is a manually controlled device like the Sanders injector, or a high frequency ventilator like the jet ventilator. The jet delivery most commonly is a supraglottic via the manually controlled injector. You can also use a rigid bronchoscope and jet down the subglottis. It's not commonly used. I, for one, haven't used a jet in years. The problem is that of barotrauma, because the jet not only entrains air from so the jet basically ventilates with the jet of air, which is 100% oxygen, plus there is air entrainment from the side, and there can be a lot of, barotrauma which can occur. Anesthesia during the jet is essentially TIVA, because there's no way you can give inhalational agents using the jet. The fourth technique is that of apneic oxygenation, or the intermittent intubation technique. Again, here, the advantage is the surgeon gets an unobstructed surgical field, but intermittently the airway is intubated by the surgeon himself. Muscle relaxants are typically used for paralysis, and oxygenation can be maintained either using high flow nasal oxygen using Thrive, or a simple nasal prongs. Anesthesia again is maintained by a total intravenous technique. The problems here is that there can be episodes of desaturation and hypercarbia, and of course a trauma of repeated intubation. But sometimes it is, necessary to use this technique if your child will not tolerate a spontaneous or a tubeless technique. Another way of managing anesthesia and oxygenation is a crossfield ventilation. Here, the endotracheal or the endobronchial tube is inserted directly into the distal trachea during tracheal surgery, and the tube is intermittently removed by the surgeon for surgical access. So here you see a surgery in progress where this is a laryngotracheal reconstruction. This is a cricoid. This is the distal trachea. And the surgery is almost ending here. So you can see that this tube, the flexometallic tube, was being intermittently inserted and removed by the surgeon. And as the surgery is now almost coming to the close, the anesthetist has inserted the tube from orally from above. And now the anterior wall of the airway will be closed over this endotracheal tube. Another way of oxygenation is ECMO or cardiopulmonary bypass. Now, sometimes when the lesions are extensive or they are very deep lesions near the carina, there's just no way you can oxygenate except put the patient on ECMO and then carry on with the procedure. We had a patient recently who had come for a bronchoalveolar lavage, and he had extensive lesions. He had bilateral, pulmonary alveolar proteinosis, and then we had put the patient on ECMO and done a complete lavage. Also in lesions, say an anterior mediastinal mass, which is very large, there is a risk of complete airway collapse at anesthetic induction, and ECMO is very useful at this time. How do you maintain anesthesia? What are the drugs which we use for such airway procedures? Now, if you're using positive pressure ventilation, putting in a tube, it will be a standard anesthetic. This is a chart which is showing the commonly used drugs which are used in a spontaneously breathing patient. The drugs which we commonly use are usually a midazolam, a bolus at induction, and then we run a dexmed infusion once the patient has come into the OR, and manage later on with ketamine and propofol boluses intermittently. We don't have access to remifentanil, but it is a great drug to use because of its short action. Coming to perioperative monitoring, standard ASA monitors. But very often when one is using a tubeless technique, it is impossible to get the CO2s, the entitled CO2. So here we rely on visual inspection of the chest rise, and we look at the rate and the depth of respiration. Analgesia is managed with fentanyl at induction, and then a combination of paracetamol and diclofenac. Topical lidocaine to the airway reduces the laryngospasm risk, and some centers also use low-dose morphine. For post-operative care, one has to watch for worsening airway obstruction. So your child could have a compromised airway at the beginning, which would become worse with edema and secretions. So we use a combination of dexamethasone IV, which is usually continued for the next 48 hours, topical epinephrine and nebulized epinephrine post-operatively. If post-procedure intubation is planned, it is important to choose the endotracheal size carefully, usually downsize one, and also sedate the child so that you reduce movement around the endotracheal tube. You have to plan for extubation as well. And very often we will plan an extubation under controlled conditions in the operating room. And very often also a prior bronchoscopy is done to ensure that all things are okay before you extubate the child. Coming to specifics of certain problems like tracheobronchial foreign bodies. Let me present a case to you. This was a 2-year-old child who presented with a history of suspected chicocere inhalation a few days back. And you can look at the X-ray. You don't really see any foreign body. And in fact, most of the foreign bodies are radiolucent. So you can see on the right side, there is hyperinflation. We subjected the child to a CT scan, and you can see the foreign body sitting here in the right main bronchus. So the anesthesia concerns when it comes to tracheobronchial foreign bodies. What is the type of induction you will plan? How will you ventilate the patient? Will you keep him on spontaneous or controlled ventilation? How will you maintain anesthesia? The choice really depends upon the clinical status of the child, the location of the foreign body, the type of bronchoscope which is used, and also the individual preference. A look at the rigid bronchoscopes. Earlier times, we would have a rigid bronchoscope, which is essentially a non-ventilating bronchoscope, which means there is no port by which you can ventilate the child. And here the method of oxygenation would be either spontaneous ventilation, or you can use jet ventilation, or just go for an apneic technique. Nowadays, we have the ventilating bronchoscope, so it's a lot easier. What we do is we connect our ventilation circuit to the side port of the ventilating bronchoscope, and then ventilate either using a JR circuit or a closed circuit. You can also use jet ventilation, and you can jet down the side arm. Now, what the surgeon will do is that he will insert the Hopkins rod lens through the lumen of the rigid bronchoscope. And essentially, he can see better. You can connect this end to the television and see a magnified image. So the ventilation actually occurs through the areolar space between the lumen of the bronchoscope and the outer surface of the telescope. So there is actually only a very small lumen or a small space which is available for ventilating the child. What is a method of induction one would use? So it depends upon where the foreign body is. Suppose it's a proximal laryngotracheal foreign body, spontaneous respiration is best preserved. This is because abolition of spontaneous breathing and the loss of laryngeal muscle tone may convert the partial obstruction into a complete airway obstruction, and then you will be in great trouble. Positive pressure ventilation may also drive the foreign body distally. If the foreign body is already lodged into the bronchus, it doesn't really matter. You can use an IV or an inhalation induction, and you can use muscle relaxant as well. Spontaneous ventilation has advantages. There is a lower risk of complete obstruction, and the ventilation can be continued during instrumentation as well. But there are several disadvantages. The patient may cough, buck, there may be trauma, there may be bronchospasm. A greater depth of anesthesia is required, and that can lead to delayed emergence. The patient may hypoventilate because you really need a good depth of anesthesia to put in that bronchoscope. And also there'll be resistance to breathing with insertion of the telescope and the forceps. Furthermore, the foreign body may slip due to vocal cord movement when you're removing the foreign body. Usually we prefer to use controlled ventilation. The advantages are good working conditions. There is less coughing, breath holding, which facilitates foreign body removal. There is also improved oxygenation, and less anesthetic is required. So there is less cardiac depression and rapid emergence as well. The disadvantages of controlled ventilation is that the partial obstruction may get converted into a total obstruction. The object may move distal into the distal airways, and there is a risk of distal air trapping by a ball valve effect. Manual jet ventilation, you need muscle relaxation for this. And you also need an unobstructed airway open to the atmosphere, otherwise there will be a risk of barotrauma and pneumothorax. You need to maintain anesthesia IV. It is advantageous, of course. It's useful in situations if you don't have a ventilating bronchoscope, you would have to use jet ventilation. And also it's useful whenever there is a large leak around the ventilating bronchoscope. If you're using IPPV, you can better oxygenate using the jet. The disadvantages are barotrauma. And also the FiO2 actually is quite low because you're not giving 100% oxygen. The patient is actually being oxygenated by the air which is entrained around the jet. There can be aspiration of debris, and quantitative assessment of ventilation with EtCO2 is not possible during jet ventilation. So let's look at this case. Suppose you have an anesthesia, you have a child who's in a stable condition. You would follow standard fasting protocol, so you can plan the case. You don't have to rush in like an emergency. You can pre-medicate the child with glycopyrrolate. You can give a small dose of ketamine. We also like to give midazolam. Induction can be a standard induction, fentanyl, propofol, atracurium. And then mask ventilation can be done till the airway is secured by the bronchoscope, the rigid bronchoscope. We connect the anesthesia circuit to the side arm of the bronchoscope, and we ventilate with 100% oxygen and higher flows of oxygen. When the surgeon is removing the eyepiece to put in the Hopkins rod telescope, we continue apneic oxygenation through the side port. We maintain anesthesia with propofol doses. So this is our patient with the Chico seat which has come out. Following that, we mask ventilate with 100% oxygen after the bronchoscope is removed. And then the surgeon might want to do a check bronchoscopy and suction to ensure all is clear. Let me present to you another case. This was a 3-year-old male. He came with history of aspiration of a light bulb. And you can see that X-ray showing that the light bulb is out here, quite high up in the larynx. How would we manage this case? We would do an inhalation induction with sevoflurane. We would give cautious doses of IV ketamine, maybe a little propofol, maintaining, always trying to see that the patient is maintaining spontaneous breathing. We would do a laryngoscopy, and if you can see the foreign body, we would remove it. In our case, we were not able to see the foreign body. So probably it has already gone a little distal. So what we would do, we would spray the larynx, oxygenate again, deepen the anesthesia, and then the surgeon would insert the rigid bronchoscope into the trachea. We would connect the oxygen through the side port and give small propofol boluses to deepen the anesthesia. Once the bronchoscope is in and the surgeon has gained control over the foreign body, we give a small dose of succinylcholine alcohol so that you can aid the extraction of the foreign body. And this was the light bulb which came out quite nicely. I now move on to the next topic, which is drug-induced sleep endoscopy. It is essentially evaluating the upper airway using a flexible endoscope. And the goal is to identify the site of obstruction in obstructive sleep apnea. The indications are several, but the topmost indication is patients with persistent OSA after tonsilloadenoidectomy. So the anesthesia for DISE should essentially simulate natural sleep and allow spontaneous ventilation. It should be quick in onset and short duration. It should not cause airway collapse beyond natural sleep. It should not cause respiratory depression and not cause airway secretions. This is a review which discusses the anesthetic protocol for pediatric DISE. Let's look at the agents. So propofol is actually quite commonly used for adult DISE, but in pediatric DISE, it tends to cause airway collapse. That's why it's not very popular. Dazolam is often used. Dexmedetomidine is a preferred medication for pediatric DISE because of its minimal effect on airway. Ketamine, again, is a good agent. It has minimal to no effect on airway patency. It does cause a bit of hypersalivation, which can make DISE a bit difficult, but we give anticholinergics for that. Inhalation agents cause dose-dependent obstruction at various sites on the upper airway, so it's not popular. This was a review which was published recently, and it looks at 12 articles, more than 1,000 children. And this review concurred that ketamine dexmed may be the best combination for pediatric DISE. Inhalation agents and opioids worsen airway obstruction, and that's why it's best avoided. In adults, usually we use BIS for DISE studies, but it's not much validated, especially in small children. So it's not that commonly used in children. Usually we look at clinical criteria, which means lack of patient movement, to look at how deep the patient is before the endoscope is kept put in the flexible scope. Coming to the last part of my topic, which is laser surgery, there are several advantages. So like precision, ability to reach distant pathology, minimal tissue handling, and that's why it's quite popular. But there are dangers of deep damage to the tissues, hitting the wrong object, injury to the personnel, and of course, the dreaded laser fire. It's important to have safety protocols in place before you begin laser procedures. Signages should be there, eye protection, and your hospital should have policies and protocols in place before you can embark on such a venture. So the essential concern about anesthesia for laser surgery is that we have an oxygen-rich environment and a source of ignition, which is a laser. So you have to use laser-specific tubes. You might also use a regular endotracheal tube with aluminum foil wrapped around it so that it deflects the laser beam. About anesthesia, you can either use laser-specific tubes, or you can use a bronchoscope, a rigid bronchoscope, with the anesthesia circuit connected to the side arm. Or you can use a tubeless technique. And here this is a standard North Polar tube, which you can cut into size, use it as a nasal airway. And here you can use these plastic tubes without having to worry, because you're not really putting it in the beam of the laser. This is just simply used for oxygenation as a nasal airway. It's important to remember that you need to avoid nitrous because it supports combustion. And you need to keep a low FiO2. So air oxygen mixtures are used for the same. A word about laser fire, best prevented. So here you can see in the picture, you can use warm wet towels over the patient's face, use low FiO2. If you're using a cuffed endotracheal tube, fill the cuffs with saline. You keep saline filled syringe ready in the case of a laser fire. In case you do encounter a laser fire, immediately turn off the laser, ventilate with air, and then, of course, assessment of burn and management protocols with steroids, antibiotics, etc. So in summary, airway surgery is a shared endeavor between surgeons and anesthesiologists. And the keys to success are understanding the pathology, clear communication and trust between providers, and proficiency in anesthetic techniques. Thank you for your attention, and I'm happy to take any questions.
Thank you very much, Dr. Nandini, for your very informative talk in anesthesia perspective for airway surgery. So there are a lot of questions coming in the Q&A box, and that will be answered shortly after we finish our anesthesia session for airway surgery. So I just would like to introduce our next speaker, Dr. Josephine Tan. She'll be giving us a talk about the challenging patients. So we understand that we have a lot of sick patient who's coming for bronchoscopy, and we have a very rough time managing that. So Dr. Jo Tan will be giving us a talk about challenging patient, challenging bronchoscopy. Dr. Jo is a senior consultant of pediatric anesthesia at KK Women and Children's Hospital. She is a deputy chair of anesthesiology and perioperative science academic clinical program at Sing Health. She is a current president of ASPA. She also a board of director, a chair, and a member of many societies of anesthesiologists. Her field of interest include effect of early anesthesia on neurocognitive development, device development to detect early extravasation, regional anesthesia, and cardiac anesthesia. Please welcome Dr. Jo Tan. She will be starting with her poll question.
Thank you, Pichaya. Good evening, everybody. We have come to almost the end of the webinar, but before I start my talk, I will have two poll questions. The first poll question is the most common complication of bronchoscopy is, choose one answer, hypoxia, bradycardia, hypertension, or bleeding. Okay, so I think majority of people have chosen hypoxia. The next poll question is the volume of normal saline used for bronchoalveolar lavage. It's no limit, you can use whatever you want. 3 mL per kilogram of body weight or 3 mL per kilogram of body weight. Choose one answer. Okay, most people have chosen 3 mL per kilogram body weight. I will start my talk now.
Beyond stridor in the pediatric airway, challenging patient, challenging bronchoscopy. I will be using a case illustration as a backbone for the talk. The case is a 2-year-old, previously well child with a 2-week history of fever, running nose, cough, and wheeze, not improving despite antibiotic and bronchodilator treatment. He is currently requiring CPAP with 2 liters per minute of oxygen to maintain saturations of 96 to 97%. His chest X-ray on admission reveals an inhaled foreign body and is now scheduled for bronchoscopic removal of airway foreign body and bronchoalveolar lavage. The job of an anesthetist is to ensure that the patient's comorbidities are optimized and made as fit as possible for the intended procedure. Understand the risks of the proposed procedure, develop a game plan to ensure ideal procedural conditions, and provide sedation and comfort. As Dr. Nandini has given a clear insight on the anesthetic management of inhaled foreign body, I will take the next 20 minutes to discuss risks, priorities, and challenges in the management of bronchoscopy in the critically ill child. Before we can start to develop a management plan, it is important to understand and appreciate what bronchoscopy entails, its indications and pathophysiological consequences. Bronchoscopy is an endoscopic technique to visualize and evaluate proximal, as well as distal airways. The main indications of bronchoscopy in critically ill patients generally revolve around inspection, maintenance of airway patency, sampling for diagnostic purposes with bronchoalveolar lavage and/or transbronchial biopsies. To safely manage a child for bronchoscopy, we must first understand the physiological effects of bronchoscopy. Transient hypoxemia is inevitable during bronchoscopy due to a combination of alveolar collapse and depletion of intra-alveolar oxygen. Bronchoscopy causes partial obstruction of the airway, leading to increased airway resistance, peak inspiratory pressure, and reduced tidal volumes. Intrinsic PEEP is also increased due to impedance to expiratory flow and insufficient time to complete expiration. Prolonged use of suctioning may also cause declines in tidal volume. Therefore, it is recommended that suction should not exceed 3 seconds. Changes in dynamic and static compliance occur primarily because of alveolar collapse, but suctioning and installation of normal saline during bronchoalveolar lavage can further worsen compliance. Unretrieved saline from bronchoalveolar lavage create ventilation perfusion mismatch, wash out surfactant, and worsen gas exchange. Bronchoscopy-induced gas exchange abnormalities occur nearly in all patients undergoing bronchoscopy to some extent and can amount up to 30% drop in oxygenation, which usually returns to baseline within a short time after end of procedure. These adverse effects are more pronounced in the critically ill, especially those with pre-existing respiratory issues, and may take up to 24 hours before stabilizing to baseline oxygen saturation levels. Hypercapnia can also occur as a result of hypoventilation caused by airway obstruction from the bronchoscope. Besides its effects on the respiratory system, bronchoscopy also affects the cardiovascular system. Cardiac output is increased from sympathetic discharge secondary to mechanical irritation of airway that occur during bronchoscopy, and returning quickly to baseline at the end of procedure. Severe hypoxia, if not rescued, can lead to bradycardia and decreased cardiac output. But in general, clinically significant major arrhythmias are infrequent. Close monitoring of oxygen saturation, pulse rate, ECG, and BP allow early recognition of cardiovascular complications and timely intervention. Bronchoscopy is by and large considered a safe procedure. However, bronchoscopy in the critically ill child is different from bronchoscopy performed in the elective patient from a home setting. Critically ill patients have a much higher risk for complications. Critically ill patients may already be hypoxic, have pre-existing airway, hemodynamic, electrolyte, and metabolic disturbances. All reversible risk factors should be corrected before undertaking bronchoscopy. Because of the fragility of the critically ill, not only indications, but also contraindications for bronchoscopy should be assessed meticulously by the anesthetist. Bronchoscopy is strongly discouraged in patients who are severely hypoxemic, requiring high FiO2 support and/or high PEEP. Unfortunately, there is no clear-cut definition for severe hypoxemia. Most agree that bronchoscopy is contraindicated if the patient is unable to maintain oxygen saturations of more than 90% on a FiO2 of 0.9 to 1, or a PaO2 to FiO2 ratio of less than 100. To reduce possible bleeding risk, platelet counts of 20,000 and above should be achieved before bronchoscopy. Once a decision is made to proceed, considerations prior to commencing bronchoscopy include appropriate fasting and optimization. Depending on the type of bronchoscopy and interventions proposed, patient transfer to OT from ICU may require some logistic planning. General ventilation strategies for safe bronchoscopy include bronchoscope equipment check to ensure at least a 2 mm gap when the flexible bronchoscope is within the endotracheal tube, titrating the FiO2 to maintain saturations of more than 90%, allowing a higher inspiratory airway pressure to facilitate adequate tidal volume delivery, and adjusting respiratory rates and expiratory times to prevent excessive intrinsic PEEP buildup. Bronchoscopy is generally well tolerated. However, we need to be extra vigilant in the critically ill patient where hypoxia and bronchospasm may continue to be present post-procedure and can lead to cardiovascular instability. Ventilation strategies implemented before and during the procedure should be continued into the post-procedural period. It is also wise to continue monitoring for potential bronchoscopic-related complications such as fever and pneumothorax in the post-procedural period. Besides flexible bronchoscopy, there is also rigid bronchoscopy. The rigid bronchoscope serves as an endotracheal tube, a conduit for ventilation and for passing dedicated instruments into the airway. The rigid bronchoscope consists of a light, hollow metal tube within which is a removable optical telescope which seals the distal end of the instrument. Ventilation occurs within the annular space between the lumen of the bronchoscope and the outer surface of the telescope. There is also a port at the distal end of the instrument for attaching the anesthetic breathing circuit. It is ideal to select a rigid bronchoscope of suitable size for the patient's airway. Large rigid scopes can compress the tracheal mucosa and result in edema. The correct size should allow an audible leak at 20 cm water or ventilating pressure. Similar to flexible bronchoscopy, complications from rigid bronchoscope depend on a variety of factors, such as the indications for the procedure, patient comorbidities, intervention, type of anesthesia used, and operator experience. Compared to flexible bronchoscopy, there may be a higher risk of trauma related to rigid bronchoscope insertion and therapeutic intervention performed through the rigid scope. Type of anesthesia may also affect outcomes of rigid bronchoscopy. Complications may be related to the use of apneic oxygenation, spontaneous ventilation, controlled ventilation, and high-frequency or manual jet ventilation. Pneumothorax from airway perforation or barotrauma is rare, but may be more common with high-frequency jet ventilation or with therapeutic procedures. Before the actual procedure, it is crucial to have a huddle with the team to agree on purpose, indication, risks, benefits, and type of bronchoscopy to be used and if additional procedures are planned. Physician skill sets differ. Flexible bronchoscopy is mostly performed by the pulmonologist or respiratory physician or anesthesiologist, and rigid bronchoscope with therapeutic instrumentation is best done by the ENT surgeon. Flexible bronchoscopy is mainly used for aiding difficult intubation, evaluation, and clearing secretions of the airways. It can be done by the bedside with sedation. Rigid bronchoscope is generally used for therapeutic procedures. Because it is generally more stimulating, rigid bronchoscope under general anesthesia in OT is preferred. Let me now move on to briefly share some notes on bronchoalveolar lavage. Bronchoalveolar lavage or BAL is a minimally invasive procedure that involves installation of sterile normal saline into a subsegment of the lung, followed by suction and collection of the instillate for analysis. A significant portion of pathological disease within the lung occurs at the alveolar level. Bronchoalveolar lavage allows for the collection of alveolar contents for analysis. Common reasons for the use of bronchoalveolar lavage include workup for opportunistic and atypical respiratory infections, unexplained radiologic pulmonary infiltrates, or hypoxia. Limited information exists on the amount of fluid and the number of aliquots that should be used in order to obtain sample representative for the alveolar compartment in children of different sizes and ages. Various protocols for bronchoalveolar lavage have been used. Some use 2 to 4 fractions of the same volume of 10 to 20 mL, irrespective of the patient's body weight and age, as in adults. Others use bronchoalveolar lavage volume according to body weight, using 3 mL per kilogram of normal saline divided into 3 equal fractions in children less than 20 kilograms, or 3 mL per kilogram in 20 ml aliquots in children more than 20 kilograms. If only 5% of each aliquot injected returns, indicating that most of the injected fluid is being retained, the procedure should be aborted. A return sample yield of 30% or more of the instillate is considered an adequate return. Now, going back to the case, this is a child with inhaled foreign body of unknown duration and is likely to have concurrent bronchiolitis with compromised respiratory function. It is important to review and optimize his clinical status and current respiratory support before the planned bronchoscopy. His impaired respiratory function may be the result of a combination of bronchiolitis and localized inflammation and irritation from the impacted inhaled foreign body. A quick discussion can be made with the pediatrician to check if inhaled bronchodilators can be further optimized and if intravenous bronchodilators should be started. Continuous monitoring for signs of respiratory distress should guide the need to escalate respiratory support. There is an urgent need to remove the inhaled foreign body, which may be responsible for the ongoing wheeze not responding to therapy. Complications related to the foreign body aspiration vary according to its location, size, and type of foreign body aspirated, whether organic or inorganic. Absence of a radiolucent foreign body does not include the presence of a non-radiolucent foreign body in the airway. Inhaled foreign bodies can be retrieved with a flexible bronchoscope, but rigid bronchoscopy is the gold standard for retrieval. In this child, where foreign body retrieval and bronchoalveolar lavage is planned, perhaps a combination of flexible and rigid scopes with the relevant expert physicians may be necessary. At the end of the procedure, if there is no severe hypoxia or surgical complications, then allow the child to emerge from general anesthesia and extubate to CPAP. As the child emerges, there is a possibility of laryngospasm. Therefore, secretions should be cleared often and possibly use an antisialoc such as glycopyrrolate. On the other hand, localized inflammation, irritation, and pulmonary parenchyma disease caused by the prolonged presence of a foreign body in the airway will not be immediately reversed following removal of the foreign body. This, together with the underlying concurrent bronchiolitis and post-bronchoalveolar lavage, a short period of post-procedural intubation and ventilation may be indicated if the child had signs of respiratory distress and possibly fatigue pre-procedure. With all that said, I will now conclude and hope that I have impressed upon you that bronchoscopy in a critically ill child is a risky business that may need a specialized care team with the right skills, knowledge, and collaboration. Thank you for your attention.
Thank you so much, Joe. That was a very, very detailed talk, but very enlightening all the same, okay, with the provision of many, many tips, okay, for us to actually keep at the back of mind when we're actually dealing with a similarly critically ill child who actually has to undergo a bronchoscopic procedure like you actually described. Okay, so at this point in time, I would like to thank all our three speakers and also open up the floor for panel discussion and for some Q&A session. Our panelists have actually been very busy, okay, with all the questions that have been coming in through the Q&A section. And so if you actually haven't asked a question yet, I would encourage you strongly to actually type your questions in the Q&A section. And even though many of our questions have actually been answered by the panelists so far, we would like to highlight some of the questions. At this point in time, I would also like to actually introduce to you our guest panelist, Prof. Joseph Holsky, who, like we kind of mentioned earlier before, even though he's actually a retired director, chairman of the Department of Pediatric Anesthesia and Surgical Intensive Care Unit in Children's Hospital Cologne in Germany, he remains a consultant in the Department of Pediatrics at the Santé Hospitalier Université Liège in Belgium, and he until recently, up to 2020, he was actually a co-researcher at the Institution for Legal Medicine, Pathological Anatomy, performing research, okay, in terms of airway injury, airway work, cuff, endotracheal tubes, etc. So, not surprisingly, his interests remain in the pediatric airway, and he continues to teach actively residents and interns, okay, in terms of pediatric airway management. So, if you've got a burning question in the airway, on airway injury or the use of endotracheal tubes, this is our guy to ask. Okay, we will strongly encourage you to actually ask any questions thus far. But at this point in time, I just want to ask the panelists. There was a question actually posed in the Q&A chat on you know, if we actually have a foreign body in the right main stem bronchus, okay, do we actually paralyze, or do we actually prefer a spontaneously breathing technique? Perhaps, okay, Prof, would you like to kind of start the ball rolling, and then we can ask the rest of the panelists to actually chime in as they do, sure, even though Dr. Nandini has actually shared quite extensively, but she may actually choose to elaborate on some of the techniques that she uses as well. Yes, Prof.
So I would still prefer inhalational, you know, and I will use rigid, and you know, it's probably a patient will just continue to insufflate oxygen, and we'll try to remove it with a tubeless technique, and most of the time should be okay, unless I have broken it into pieces. At the end of the procedure, if they are too far out, then I will ask the endoscopists, flexible endoscopists, come and help me. Right.
Okay. So the conditions, okay, that you actually like at this point in time, Prof, what would they be?
Sorry, what's your question?
You know, the conditions, the operating conditions for the child during this time, what would you like it to be when you're actually trying to retrieve the foreign body?
I would like, of course, a child to be quiet if possible. Of course, you've got to spray the larynx for me and then anesthetize properly. And then I will try to use my rigid, and then you insufflate your oxygen through my rigid endoscope, my rigid bronchoscope. Then I would usually use endoscopic forceps to remove if possible, which I can see with my personal visual view on the TV, and the assistants can see as well.
Okay, thank you very much.
Thank you.
Thank you, Prof. Okay, so obviously, okay, having a well-topicalized airway with a child sufficiently anesthetized is definitely important, and yet is important, and in Prof's, as Prof actually alluded to, that the child actually continues to actually breathe spontaneously, since Prof, in this particular instance, you prefer a tubeless technique. Would our anesthetists, okay, like to chime in, Dr. Nandini or Dr. Joe?
So it is my practice, Dr. Evangeline, to usually give a muscle relaxant for such
Mhm.
procedures, and the endoscopist will put in the rigid bronchoscope, and we will
Right.
gently be ventilating through the side port.
Right.
Except if it is a laryngotracheal foreign body, which is just the causing stridor, and the patient is really gasping for breath, typically because it's an upper airway foreign body. Those the kind of children where we would do it under spontaneous inhalation technique. But usually we find that with a foreign body which is in the distal, it's in the bronchus or even distal, it usually is more comfortable for the endoscopist also to have the patient under muscle relaxant with us gently ventilating.
Right, thank you. And your muscle relaxant of choice in this instance would be a short-acting one like Succinylcholine. Choline.
So we ask our surgeon how long it is going to take. It also depends upon what is the foreign body, how much time it has been there. And we usually feel that if we can give a small dose of intermittent acting relaxant, like say atracurine, which is what is most commonly used, the surgeon usually takes about half an hour by the time our child is out. So by the time the procedure is over, we are, he's already breathing.
Okay, and you're able to reverse the child. Yes. Okay, Joe, do you have any opinion on this?
I think some people fear the use of sucks and repeated sucks. So I agree with Nandini. Most of the time, the procedure would take at least half an hour. I may choose to use rocuronium, and rocuronium may be quickly reversed with Sugammadex in case I run into any airway problems. So I guess the concept is the same as Dr. Nandini.
Okay. Sure. For me personally, I will actually work with the surgeon and actually, communicate, as to what kind of conditions he actually wants. If he really wants a completely still feel and there are provisions for me to be able to ventilate, for example, through a side port of a ventilating bronchoscope, then clearly, the use of a muscle relaxant, whether it's atracurium, rocuronium, or sucks, or whatever it is, depending on how long it is, that probably would be a reasonable way to go. But on the other hand, the procedurist is actually very comfortable and decides that with the child spontaneously breathing, and so long as the airway is well topicalized and anesthetized, they'll be able to retrieve it. Then I do think it's also, I should also be able to provide the conditions for the child to continue spontaneously breathing, even as the foreign body is actually retrieved. So I do think that's possibly one of the things that we want to take away with us, is basically to actually just communicate with our procedures and work alongside to be able to provide the conditions, that would be necessary to facilitate the fast removal of the foreign body. All right, Dr. Holsky, do you have any input on this?
Well, everything has been said already, but we have a little bit of a different approach in the sense that we as anesthesiologists do the endoscopies. Our ENT surgeons are 6 kilometers away, and we always start with inhalation anesthesia. We give sucks because it reverses after a while if we get into trouble, and we enter first with the Hopkins lens, with the telescopic lens, because we don't really touch the walls of the trachea, and we have foreign bodies where we might want to change the position if it's a piece of broken glass, for instance, or if it's a piece of wire which is curled a little bit, and then to position it that you can get with your forceps over the sharp edge and pull it out without a rigid scope in order not to injure the wall of the trachea, or if the danger is too great, then go down with a rigid tube and try to manipulate the sharp edge into the bronchoscope. But I think that's what everybody does anyway.
Thank you very much, Dr. Holsky. I think along this line, there were some questions about the use of lignocaine for topicalization. Well, actually, in all honesty, either the anesthetist or the surgeons can actually topicalize the airway. All you need to do is make sure that one of us actually does it by actually communicating ahead of time. There was also a question as to whether aspiration might be a concern when we actually topicalize the airway. First and foremost, I think we need to keep at the back of our mind, okay, that there is a toxic dose, okay, of local anesthetic that we need to keep at the back of our mind. You do need to be mindful about the volume that you give. You don't actually have to give a lot of volume in order to topicalize the airway. The other thing, of course, to bear in mind is that if you actually topicalize the airway, then you probably will want to be a little bit mindful as to when you allow the child to feed. You definitely will want to ensure that the child has actually the return of a cough reflex, so that you make sure that aspiration is not actually on the cards, okay, soon after. So typically we may keep the child near my mouth for additional 2 to 4 hours after actually topicalization of the airway. So I kind of hope that that kind of helps along with the question. Okay, so just another question for Prof. I think you may have answered this, but there was also another question about whether spontaneous breathing or muscle relaxation is preferred for the use of laser, microdebrider, or coblator. And I think you did mention that for a laser, you prefer a tubeless technique.
Yes.
But the rest of it, the use of a tube basically can be present, isn't it? But does it also depend on where the lesion is that you're actually trying to remove?
Yes. Honestly, when you laser, for example, in the subglottic region or at the vocal cord, you really will prefer no movements. If the vocal cord is open and close, then you really go to hit it, you know. So then I will need your help to make sure that you either, you know, temporarily stop that movement for me with your muscle relaxant or, you know, paralysis or whatever. So, and the coblator, if it's supraglottis, then you don't need to paralyze at all. I can remove a, you know, cystic lesion, for example, vallicular cyst, without the child being paralyzed. So the coblator is, you know, fairly easy on the top. So it's mainly we worry about injury of important organs like vocal cord, so that we will have a voice problem afterwards. We try to avoid that. Yeah.
Okay, thank you very much, Prof. So I hope that kind of answers the question, okay, that was actually posed in the chat. At this point in time, I just want to invite Prof. Holsky. Can you just tell us in your, you know, your extensive experience with airway, looking at airway injuries, etc., what is the most important lesson do you think that anesthetists should actually be aware of when actually managing the airway?
Well, I think the most important is to cooperate with ENT surgeons, pediatric ENT surgeons, in all fields of what has to do with the airway. And I see in my practice, and even till now where I'm a consultant, that anesthesiologists, in particular those who do only occasionally children, they do all kind of procedures and just forget to ask somebody to take a Hopkins lesson and look into the airway. For instance, my experience is with severe injuries after cuff intubation, overinflation of the cuff, placing cuffs, even the smallest cuff, ID 3 millimeters of the microcuff type. They are used today and placed into premature children. But the airway of the premature children is too small for these tubes. And it's well known from the pediatric ENT surgeon from Paediatric in Belgium that the premature airway, you can even dilate the cricoid outlet a little bit. And so just pushing down the tube and say, oh, everything is fine. Afterwards, the child has no stridor for a while. And then they have stridor, and then they do all kind of lavage and whatever, and make MRIs, CT scans, and so. And it was forgotten for a year in several cases to have a look into the larynx and the trachea and find a stenosis. So I think that's very, very important.
Okay, thank you very much. Yeah, so I think the takeaway messages is that, especially in the very, very small ones, you really need to be very mindful about tracheal injuries, okay? Even in this age where the use of cuff tubes is getting more popular, we need to be mindful about where the depth at which we actually place a tube in. Otherwise, a cuff can actually cause problems still, right? Particularly in the very small premature neonatal airways.
Yeah,
Have I got you correct?
Yeah, right. No, it's not correct. And what we did just in the pathology department the last 4 to 5 years, showing that in not only in the small children, but in the older children, preschool children, microcuff is so popular and it's so well advertised. Actually all proximal cuffs stay in the outlet of the cricoid. And that's not acceptable. And again, one should ask the pediatric ENT staff. They see the results and the child didn't have stridor for 2 or 3 months and then suddenly there is stridor and they do lavage. No, somebody should look with a Hopkins lens, not touching greatly the walls of everything, and have a look what's there, and the surprise will be great. And then with that diagnosis, the children are in the right hands, in the hands of the ENT surgeon.
I just want to agree with Professor Hofsky that, for younger children, neonates or younger infants, we try not to use a cuff tube. Even a tracheostomy tube, we will try to use the non-cuff if possible. Because the narrowest airway is actually the subglottis. Yes. That actually is already working as a cuff for the tube. So, yes. A cuffless tube will be much more friendlier for the airway. Less contact, less granulations.
Okay, that's great.
Much. It's such an important message. It should be written in red letters.
Okay, thank you very much both for your inputs. Okay, Pichai, would you like to continue on the other questions?
Yeah.
All right, so thank you, Evangeline. So I just have a couple of questions, since many people really worry about how to put patient, how to anesthetize patient to provide spontaneous breathing adequately without any complications or laryngospasm. I just want to ask how to do it in terms of your personal techniques. I'm going to start with Dr. Nandini then.
I think there's no one magic answer. I would start with sevoflurane, because with spontaneous technique, you want to preserve respiration. So with sevoflurane, the child will guide his or her own anesthetic depth. In order to deepen the anesthetic, I would be giving ketamine. Works well. It's important to use low doses, titrate it, wait for the effect, and then go on to give the next dose. That's about it. Dexmed to me is a good agent because it preserves ventilation quite nicely. I usually don't try to bolus that initial dose. I would just start at, say, about 0.5 mics per kg per hour and keep it at that, and then increase it if need be. If the child has been very anxious, his dose requirement is going to be higher. So in those kids, or maybe if the surgeon is very anxious to go in very early, then I might give that initial loading dose before starting the infusion. But usually for me, about 0.5 to 0.7 mics works, along with the sevoflurane, a little bit of ketamine, maybe a little bit of propofol also. It all depends upon the child, how much is the requirement. And, does that answer your question?
Yeah, thank you. And how about your technique, Dr. Joe?
Sorry, Joe, yeah.
For sleep endoscopy?
Yes, and for any procedures that we need to get the child spontaneously breathing.
Most of the time for the younger kids, we still use an inhalational induction. I think topicalizing the airway is useful. Of course, keeping in mind the toxic dose, because it does cut down the sevoflurane requirements. Because if you don't and you use high sevoflurane requirements, then your BP might become a bit soft. And of course, if needed, if the child is a bit bigger, maybe some titrated small amounts of fentanyl helps to take the pain away and therefore reduces the incidence of laryngospasm. So I think all those things, I think adequate anesthesia is the main thing to achieve. For sleep endoscopy, I usually use, I start with a bolus over 10 to 20 minutes, because I find the cases that I do, even after the bolus, they are still moving. So I might, at that point in time, I might just give a small bolus at the start with a little bit of propofol, even after the dexmedetomidine bolus. And then usually no need more than just a small propofol bolus at the beginning, and then the dexmedetomidine will just take over. And most of the time, I will just leave the patient on dexmedetomidine for sleep endoscopies.
Thank you.
So I tend not to use ketamine.
Right. Yeah. Okay. I think generally it's pretty much an art form. Knowing the science of all our drugs is important, but it's pretty much an art form. I think we all agree with that, because honestly, different patients also have different requirements as well. I do think in this day and age, while clinical monitoring is still the most important, we do have some adjuncts that can help us along the way. Things like depth of anesthesia monitoring, things like TCI pumps, etc., that can kind of help us along the way. But at the end of the day, you really still need to keep watch over your patient and make sure your patient doesn't go apneic while being fairly deeply sedated. Dr. Nandini, I do have one question, because you did mention that rapid sequence induction has no role in pediatrics. Do you think you could kind of elaborate and clarify what you actually meant by that?
So essentially, we're talking about patients who are not fasted adequately, patients who are what we call terminology of full stomach. So earlier we would be, giving the succinylcholine. We would be applying the cricoid pressure and not ventilating patients, like is the practice in adults. The problem with this rapid sequence induction is that they don't tolerate apnea as well, because of the reason the physiology is different, the reserve is different, their oxygen requirement is much more. So essentially, what the modified rapid sequence induction is that we pre-oxygenate, of course. And after we induce, we give the muscle relaxant. It need not be succinylcholine, because most of us have stopped using succinylcholine. You may use an intermediate active relaxant. You may use rocuronium. You may use atracurium as your preference. We don't apply the cricoid pressure, because cricoid pressure tends to obscure the view of the larynx. So when the laryngoscopist goes in, it may be too much pressure for the child, and you wouldn't be able to intubate as well. So cricoid pressure is out, and it is actually gentle IPPV with a pressure not more than 12 centimeters of water, which is recommended. So you can turn the APL valve to 12, gently ventilate for the time you are waiting for the relaxant to take effect, and then intubate.
Thank you so much for enlightening us on this modified rapid sequence induction then that we actually talk about. Okay, one last question, Prof. Henry, okay, if you don't mind. So you did mention that propranolol is one of the medical ways in which you can actually treat lesions. Are there any other medication that can actually be used, which you actually apply during endoscopy, that we as anesthetists need to be aware of, and what implications does it have for us in terms of airway management after you actually apply those topicals?
So, propranolol is actually one of the best discoveries. Although it has cut down a lot of our surgeries, but the patient benefits a lot. Without surgery, the hemangioma just disappear. As long as you make sure that the patient can go without intubation and then take the propranolol and be able to survive, don't need to be in a hospital, then everything will be very good. The other medication which we use commonly in the airway by a lot of ENT surgeons is mitomycin C, which is supposed to reduce scarring, reduce granulation growth, and all these things. There are two schools of thoughts. Some ENT surgeons believe in it, some don't. So like patients with granulation or subglottic stenosis, so after we cut, we dilate, then we will apply the mitomycin that will stop the, supposed to stop the growth of the scar tissues. So that is the other medication which I can introduce to you guys.
Okay, thank you very much, Prof. And at this point in time, I just want to say thank you so much to all our panelists, Prof. Henry Tan, Prof. Hulski, Dr. Josephine Tan, as well as Dr. Nandini, okay, for actually giving us so much food for thought and for learning. And also, I just want to thank Dr. Pichaya as well. I'm actually at this point in time, due to time constraints, going to close this panel discussion, but I thank you so much, the audience too, for all your questions, okay, and for being so forthcoming in terms of asking. We have a couple of additional housekeeping rules. Just to remind you, for those of you who need a certificate of attendance, that you will get it only if you actually submit a post-webinar survey, which would be posted to your email tomorrow at 1700 hours Singapore time. So please make sure that you've correctly keyed in your full name as well as your email. We also would like you to encourage you to follow us, okay, on Facebook as well as YouTube, okay, and visit our website if you can. Also, we would like to highlight that ASPA 2022 is in Istanbul, Turkey this year, and it's face-to-face as well, although there are segments in which there will be virtual segments as well. So for those of you who are able to make the trip over to Istanbul, Turkey, we would like to encourage you to do so. And we also have got some information for the ASPA members. Okay, there is actually going to be a annual general meeting on the 24th of July. So do register and attend if you're actually able to. And then just to reiterate again, the mission of ASPA, which is basically to foster the highest standard of pediatric anesthesia care in Asia. And we are not for-profit group. We will depend on donations to actually help us be able to provide education, such as this ASPA FLEX webinar series, okay, to make it available to Asian countries, those who may not be able to have access so readily, okay, to teaching programs like this. And at this point in time, I want to highlight the next webinar will be next month on the 17th of July, and it will be on scoliosis, teamwork at its best. So do join us on a third Sunday next month. Until then, goodbye and take care. Thank you very much.